to Diana. I am Richelle Koopman. I am a family physician researcher, associate professor, and the director of research in the Department of Family and Community Medicine here at Missouri. We're going to talk about electronic clinical decision support in diabetes care. Mostly it's going to be a personal journey that takes you into, gives you a window into a little bit of the research that we've been doing over time in this area. Yeah, okay, there. I have no conflicts to declare, and this work was funded by 2 ARC grants, but does not necessarily reflect their ideas and opinions. So the objectives are going to be to look at good information design and how that affects the acquisition of information needed for diabetes care, and illustrate the importance of human factors principles in providing good care, and then look at the future of data visualization for providing care. So in designing electronic health record tools, we need to understand what the information needs of the user are, and then understand further what their tasks are, the context of the work, and then design to make the information clear and help them with decision making, which in my opinion would be shared decision making, and that we're designing shared displays that the patient can also participate in the decision making. So a little bit of history. I actually practiced with this relic called a paper chart. And EHRs have evolved, and I've seen the entire evolution from standalone EHR in the hospital to then being able to get labs, which we thought was just, the best thing since sliced bread. But, getting discharge summaries and ER information we still couldn't get. We couldn't get the consultant reports. We could not link the hospital and the office, and now that's all been accomplished. To e-prescribing, to linking the patient in with patient portals and transparency of medical records, and now health information exchange, sharing information across systems, which is a highly more personal than technological, shall we say. But there's really been an evolution to where we are in EHRs right now, but it did begin this way. And so this had a big effect on the way that EHRs were designed. You see these tab dividers along the right. You would go under there to find your labs, to find x-rays. There'd be different tabs for different types of things. There'd usually be some kind of base sheet on the left that listed all the problems, and maybe it was a flow sheet. You would put flow sheets for A1C or Coumadin flow sheets. And so the important things you would put over here, and then you could go all through the chart over here, and you'd have your outside records under one of the tabs. And then when they designed EHRs, they mimicked this system of tab dividers to make it comfortable for physicians. But the thing was then you negotiate the different tabs to get to different information. So this is the problem list. And then you go to this other place for the medication profile, this other place for labs, another place for radiology results, another screen for vital signs, and another screen to look at the actual node documentations. So when we wanted to figure out what we needed for diabetes care, we would have to go through all those things. So a little word about cognition here and working memory. So sensory memory is immediate memory, like, ooh, I smell bougainvilleas. That reminds me of when I was in New Orleans. It's pre-attentive. It's even before working memory. It just, whoo, bougainvillea, New Orleans. It just goes that way. But working memory is where we do all of our thinking. And it's a very small place. It's 7 plus or minus 2 digits, like a telephone number. For complex ideas, it's even smaller. If you were to try to remember the dosage of medication, how it was given, and the name of the medication, even a skilled physician could probably do 4 of those, maybe because they're used to them. But those are complex ideas, and you as the ideas get more complex, you can work with less and less of them for when you're actually thinking. And so the amount of processing that is going on there is often called load, cognitive load, and it can involve 3 types of processing. Essential processing is doing the job at hand. That's where you want to spend all your time. However, frequently we have to do incidental processing, which is processing other stuff that we see that's impeding on our processing, but isn't really what we want to be doing. And then often we need to do representational holding, where we're holding something in working memory while looking at something else and trying to put those two together. So holding a verbal or visual representation in our memory. And I'll show you what these look like. So this is a note about a sore throat. And there are 3 essential pieces of information on there, which is that the person has a sore throat, they had fever to 102.5, and it's been going on for 2 days. The rest of that stuff in the yellow is essentially junk. But to get to the good stuff, you have to also go through the junk. But less would be more. So that's the stuff in the yellow is your incidental processing, and it interferes with our job. This is representational holding. I've got colace, which is a stool softener, highlighted here for some reason, but what I really want you to look at is amlodipine. Because in its highest dose, which is shown here, it interacts with simvastatin at its highest dose, but only when they're both at their highest doses. So in order to figure that out, you'd have to look and see if they were on those 2 medicines. And this is amlodipine at the highest dose, but we don't see simvastatin here at all, except if you scroll down, you can see that the person is on simvastatin at 40 milligrams, which is the highest dose. And so we want to get this person down on lower doses of one of those 2 medicines or change one of the medicines so that they didn't have breakdown of muscle protein. However, you'll notice when you scroll down to get to simvastatin, you now do not have amlodipine on the screen. And so you have to hold in your memory that they're on amlodipine 10 milligrams, which isn't so hard, but when it gets more complicated, it gets harder and harder. So that's representational holding. And when things are really hard, this is what cognitive load feels like. In a medical setting, it looks like this. People are frustrated, or worse yet, on the right, this doctor is actually using a paper chart, which is interesting, and he's just stuck. He's trying to process something, and he's kind of stuck, and the patient is like, "Don't you know me, doc? Look at me. What do you have your nose in the record for? What are you doing over there?" And people just are trying to work so hard to get things done that they get stuck. This is one of our solves for the problem, and this came out, our paper on this came out in 2011, but the dashboard was a little before that. And we used user-centered design to figure out what clinicians needed to take care of patients with diabetes. And we put all the important things we thought in this numeric part of the screen to the right. And it's the last 2 episodes of all the important things. And then the problem list and the allergies and the home medication are on the left. And you can see at a glance where you're at. Even better, we looked at these quality measurements here at the bottom, and we put red dots on the ones that you weren't meeting. And so this is a nudge to do better. And while this was going on, we had a campaign to get the red out and get all the quality measures to where they needed to be. This is a much better organization of information. And in fact, we had physicians page through a chart to find 10 pieces of quality information about diabetes. Those 8 plus smoking status and one other thing. And then we had them use the dashboard. And of course, we saved them almost 5 minutes in looking for needed diabetes information, 60 clicks, and we also increased their accuracy. Plus, they were enormously satisfied because, say, who doesn't want to save 5 minutes and 60 clicks? They also told us that if they couldn't find a piece of information in the, scrolling through the chart, that they would satisfice, that they would use whatever information they had. They would ask the patient, they would ask the nurse. If they didn't get the information when going through the chart for 5 minutes, they'd just go on without it. And that's not ideal patient care. So human factors engineering are the principles that we've been thinking about, and I like to think of human factors engineering, there are many definitions, but I like to think of it as making it easy to do the right thing and hard to do the wrong thing. And this is a really nice example of this. This is a real life example from the used to be practice partner, now McKesson EHR. The medications were listed from least potent to strongest. So you'd have lisinopril 5, lisinopril 10, lisinopril 20, lisinopril 40. Amitriptyline ended up being an exception to this somehow, and you can see how this is listed. It goes 100, 25, 50, 75, 10. So that the 100 and the 10 were somehow transposed. This actually caused an 80-year-old woman to be not hospitalized, but taken to the emergency room because she was prescribed amitriptyline 100 milligrams, something any physician in their right mind would never do. And in fact, the physician meant to prescribe amitriptyline 10, but because it was ordered incorrectly, they did the wrong thing. And an assumption of human factors engineering is that every person in healthcare is doing their level best to get it exactly right every time, but that you can make them mess up if you distract them, provide less than ideal conditions, provide time pressure, and then throw in one of these. And so it is really easy to make people mess up if you provide them with information in the wrong way. So I want to look a little bit at medication lists and want to give credit to Jeff Belden and Catherine Plaisant. Jeff Belden is here in family medicine, and Catherine Plaisant is at the University of Maryland, and she's a human-computer interaction scientist. So this is a medication list in a progress note. This is what it looks like, and you can see that it's really difficult to read and get the essence of what the patient is on. With just a few rearrangements and providing a little less information, like not putting in the number of tablets and not putting in things like oral for people who are outpatients, like we know that. You can make this much easier to read. We've highlighted the medicines themselves and then just provided the dose. And it's really light here, but it does say 1 tablet daily. It tells how the patient's supposed to take it. I apologize, it looks really light. Let's talk about how managing medication renewals. A lot of times patients will come in and they'll say, I don't know what I need renewals on. You tell me what's running out and go ahead and renew them. Well, there's actually a lot of cognitive work involved in that. And this is our EHR. If you want to look at the refills, this is the path that your eye actually has to take. You have to look, find the refill number, find the refill number, find the refill number, and then you have to figure out which one has 0 refills. It is actually a tremendous cognitive effort to try to do this. You could sort by last updated, but it's actually not reliable if the number of refills is 12, because it just isn't. A lot of this comes from this ebook, which is free, that Jeff is the lead author of, and Dr. Plaisant and I are co-authors on it, that looks at, called Inspired EHRs Designed for Clinicians, that looks at a lot of the parts of the chart that we use and the tests that we do. It has clinical scenarios, it has images, it has links to human factors principles, along with whole human factors chapters with examples that then link back to EHR tasks. And this is Catherine Plaisant's medication reconciliation tool. So this is, the 2 columns are what the person's taking as an outpatient on the left and what the person is taking as an inpatient on the right. And because there's 2 names, at least for every medicine, this can often be a very difficult task. So this twin list separates things into what's unique from home, what seems to be similar with the hospital, what's identical to the hospital, and what is unique to the hospital. And then I'll show you a little video of how this works. So here's the list. The identical things go together. The unique things go to the side. The things that are similar come together. It's rearranged them, and as Catherine would say, she's French, et voila. It's easy to figure out. These are the same. These are also the same. And these are the unique medications that you need to make decisions about. And now, back to the show. Okay.
Is Cerner doing this?
Is Cerner doing twin list? Not yet, but the code is free. It's open source. As is all the code in our EHR design book. It's all on GitHub, and it's just there for the taking, because we want to make things better. The medication timeline is another way to make things better. This is telling the story of the medications. Like, when did we start them? Why did we stop them? Why did we change? Why isn't the patient taking what you think they're supposed to be taking? And this is really hard information to find. Like, if you've ever tried to find if a patient has previously been on lisinopril and why they're not on it now, it's a lot of digging through the chart. So the medication timeline makes that job a lot easier. That's picture's a little bit fuzzy. The next one's nicer. So you can see from this timeline that the patient wasn't always on simvastatin here, which is the one with the red. Darker lines are bigger doses, and so this patient started out on 40 simvastatin, and then we see a super maximal dose of 80, and then back down to 40 when somebody realizes that. We can see that citalopram started at 10. There's a gap in adherence or something. Back on 10, increased to 20, increased to 40, back down perhaps to 20. Yes, back down to 20. That's where they're at now. And you can really tell the story of how a patient began taking their medications. You can see that metformin was increased from 500 to 1,000 BID, and when that happened, very easily, at a glance. Well, what if we linked it to other clinical information like blood pressure? That would be cool. So let's talk a little bit about blood pressure, which 2/3 of people with diabetes have. Possibly the most important determinant of cardiovascular disease and diabetes is blood pressure. So it's very important. 80 million US adults have diagnosed hypertension, and 77% of that 80 million are on an antihypertensive medicine. But guess what? Only 46% of them have, 46% of them have uncontrolled blood pressure. So just over half have their blood pressure controlled, and most of them are on medication. What's up? Well, it's probably just that, most people are bad doctors, and we're better than that. I'm sure we're doing better than that here at the university, right? So we have 16,000 patients with diagnosed hypertension and failing medicine, and 47% of them have uncontrolled blood pressure. Okay, there must be something going on. It's not bad doctors, for sure now. But there is something going on, and it has to be a human factors thing, because we measure blood pressure at every visit. We have good medicines. There's several classes of medicines. Many of them have low side effect profiles. Many of them are inexpensive. And this is an emphasized goal. We know blood pressure is really important. So why are we doing so abysmally? All of us. I looked at my own personal one. It's the same. It was a little better, but it's the same. So, sometimes patients are on multiple medicines and they're still not a goal. Sometimes patients don't take their medicines, or they take them in a different way than they're supposed to. Sometimes they do stop them for side effects, but I think one of the biggest things is clinical inertia, which is that we fail to intensify medicine even when it's needed. And this has been documented. At any particular office visit, the likelihood that a physician will intensify a patient's medication in response to uncontrolled blood pressure, uncontrolled blood glucose, or uncontrolled lipids is only 20%. That's horrendous. But clinical uncertainty about the representativeness of any one clinic blood pressure is a prominent reason that most providers don't intensify therapy. So why is it that we don't trust the blood pressure when we do it with the correct technique in the clinic? There's always a negotiation about whether this really represents what is going on with the patient in all the rest of their life. And the patient says, Doc, at home, my home blood pressure monitor, I'm 130/75. I'm not getting 150/90 like you are getting here. And in fact, when that patient brings their blood pressure monitor into the office, they measure 150/90 in the office because they're having white coat hypertension. It's even more complicated than that. In order to figure out what's the true blood pressure, we have to process a large table of numbers and verbal reports about what it is in the community, and perhaps paper recordings of the patient's blood pressure at home, and then ascertain whether they're currently on medicine and make a judgment about whether this does really represent their true blood pressure, negotiate a decision about treatment, and then create a plan to make more data. So this was very interesting to me. This is a New York Times journalist who does not have high blood pressure. But she got it in her head she was going to go for a physical, and she got a blood pressure monitor. So she decided to check her blood pressure. The first night, her systolic blood pressure to her was scary at 137. She considers herself not to be even near having high blood pressure. But then the next night it was 117. The next morning, before she was going to go into her doctor, it was 152, which is huge, with 140, below 140 being normal. At the doctor's office, it was 150, and then that night it had plummeted to 110. So what's a educated person to make of all of these numbers? Well, this is a graph of a 24-hour monitoring of a patient with hypertension. And you can see, or actually, that here's 140. Most of their readings, except when they get up in the morning, are below 140. But they actually the systolic goes as low as 100 here overnight. But it's as high as 160 in the morning. What is their blood pressure? And this really requires a lot of cognitive work on the part of the patient and the doctor to make a decision about the true blood pressure. So graphs are a great solution to this. This is from our EHR. They're very simplistic graphs. They have two red lines that show where the normal range is. For diabetes, it would be slightly lower. These are set at 140 and 90. And you can see that this patient's diastolic on the bottom is nearly always in control, but their systolic goes above and below that red line. And so is this patient in control, or are they not in control? They're not in control right now, but they are in control right now, but there's been times when they've not been in control. So we designed this graph to show both home and office blood pressures. And we're actually have the office blood pressures floating off the line in this graph, and the home blood pressures on the line. And then we have confirmed and not confirmed. Confirmed is if you bring it into the office and it matches up with ours. And you can see that over time, this patient's blood pressure has gotten better, and that their clinic blood pressures are just slightly above home blood pressures, which is true, usually. Now, what if we match this with the medication timeline? Wouldn't that be cool? So now we're in color, because sometimes if you have a high one, like that orange one there in early or late 2013, and a low one, sometimes it was hard to tell what was systolic and diastolic. But if you hook these two things together, this now tells a real story. And we showed this to patients, and they could tell us the story. And here's what they said. They said, this person was on this medicine, hydrochlorothiazide, and they were really not in control, and then the doctor added lisinopril and their blood pressure was in control. And then it seems like the patient stopped coming to the doctor and stopped taking their medicine. And their blood pressure went back up. And then the doctor restarted them on what they were on before, but now it's not controlling their blood pressure. And the patients were able to get this from this graph. And if the patients can get it, we can get it too. So that's cool. And we're going way beyond just having that one clinic blood pressure and a table of numbers to help us make these decisions. Then we have a bunch of variations of this. And you can see in the upper right, it's highlighted that it says home, and we call this vivid soft. So that home is now vivid and the office blood pressures are soft. And the idea is that you can toggle between the home and the office blood pressures, depending on which ones you want to focus on. And so you could just toggle that on and off like that. And you might be wondering about home blood pressure. Home blood pressure goal is probably 5 points lower, 135/85, or lower for people with diabetes. And the home blood pressure correlates very well with cardiovascular outcomes, better than the office blood pressures. Not quite as well as 24-hour ambulatory monitoring, which I showed the picture of, but that's a highly intensive thing to do. And it's probably a better measure of blood pressure control, but we've been prioritizing our clinic blood pressures over it for quite a long time now. What if you could also put annotations on there? So this one says, this is a little hard to read. This one down here says, lisinopril stopped due to cough. That would be good to know. This one says, insurance coverage forced medication change. That would be good to know. And up there, the patient added the annotation that says that the stress of their father's hospitalization and their daughter's wedding currently has their blood pressure higher than it usually is, which is what we hear that a lot. So annotations would be helpful too. I've said that home blood pressure is really superior to clinic blood pressure, but we keep using clinic blood pressure. And that's because there are real barriers to using home blood pressure in the clinical setting. And most of it is this. This is the way we get home blood pressures. People bring in these lists. This is about 3 weeks worth of blood pressures and pulse from this patient. Here's another one. This is my patient. These are all my patients, actually. This patient takes her blood pressure and pulse 6 times a day, 3 times in the morning, 3 times at night. And pulse rate too, because this patient has atrial fibrillation. So she's on it. Almost all of these blood pressures are normal. It's, very normal. I don't know why she spends so much time doing this, but that's okay. But you can imagine when she comes in every 3 months, she brings me 3 of these sheets. And so then what do? I do what every other doctor does because we've asked them. I look through the sheets. I make a Gestalt average based on 2 seconds of looking at and I put like a range. And if you're lucky, I enter it as discrete data in the vital signs as a home blood pressure. But more likely, I enter it in the text of my note where it is completely lost. It goes nowhere. Plus, I've taken hundreds of data points and reduced them down to my Gestalt average. And every doctor does this. We've asked them. Here's another one. This is July on the left. Don't even know if it's August on the right. And what's this other number over here? Is that pulse or is it blood sugar? Well, we've got the telltale sign of little spots of blood on the paper. So it has to be blood sugar. This is a patient with diabetes. She's 90 years old now, and those are her blood pressures. It runs a little high because she has aortic stenosis, and we like to keep it that way because if we don't, she falls over, which means that our goals need to be customizable for the individual patients when we have our goal ranges. So this creates quite a bit of information overload for physicians. if you could graph the patient's blood pressure, it's not necessarily any better. So on the top is 2 weeks of a patient's real blood pressures, and on the bottom is 3 months of a patient's real blood pressures, home blood pressures. There are hundreds of data points in these graphs, and it's kind of hard to figure out, is this, I mean, the top one is clearly not in control. The bottom one's a little trickier as it's going above and below the line. And we've actually taken patients with hypertension and had them look at graphs, and when there's more variability in the line, they have a harder time making a judgment about the mean. They're less accurate, and it takes them more time. So what is probably going to be needed is some type of smoothing function, and that's what's going on here. So there's, in the background of the light green line and the light cinnamon line, these are mint and mocha, I believe, right? These two colors. And there are hundreds of data points going up and down, up and down, up and down. And when you look at it, if you were to dismiss the bright lines in front, you would have a hard time saying, is this patient in control or not in control? But when we use the smoothing function that looks at the average, it becomes much clearer that yes, the patient is in control. And then we've got our medication timeline to tell us why the patient's in control.
Can I interrupt?
Yeah,
briefly,
what's up?
Richelle?
Yeah.
Smoothing is really complicated, right?
Right.
You have to decide how you're going to smooth. Is there any evidence to guide your smoothing?
Nope, we use a LOS smoothing algorithm,
Right.
and you have to specify the
smooth
different parameters,
by
yes.
whatever window in it would make a difference.
Right, and so we looked at, we're using a sliding 2-week window, I
Okay.
believe, yeah.
But that's clinical judgment, right?
Yeah, and what we did is we altered the parameters a bunch. So I think the one that you get the most, correct me if I'm wrong, is the D parameter. You get the most play in that one. And we altered them, and we just figured out what people seem to like the best among clinicians. And so, do you like, if the data really looks like this, do you like your smoothing line to be, like this? Or do you prefer one that maybe follows a little bit more and looks like this? And most people prefer the more smooth line.
Right.
Now, what makes us feel comfortable about that is that when you look at the literature, the variability, there's some things about people who your blood pressure should dip at night. If you're a non-dipper, that's a risk for cardiovascular disease. But overall, the variability of your blood pressure is much less predictive of cardiovascular outcomes than the mean. And so what should be important to us is discerning the mean. And if we are hiding variability with the smoothing line, which we're not, it's still there, it only helps in decision making and doesn't really hide something that could be a bad outcome for the patient. So that's our rationale on being smoother.
Mm-hmm.
Yeah.
Thanks.
Yeah. That's a very good question. And in fact, it's almost time for questions. So for the future, I think it's going to be very important to be incorporating patient-generated data and moving from the page paradigm to data visualization and designing for shared physician-patient experience. And this is my clinic, and that's me, and that's not a patient, that's my husband. But we have our big old screens mounted on the wall, and everything is on view for the patient. And so you can show them things, and you should be able to show them things, and it's their data, and it's their life, and it's their decision. And so they should be full participants, and we should be designing for them to be those participants in a shared decision making. And that is the end. So thanks for your attentiveness. I know you all were just at another presentation. Any other questions? Yes.
Yeah, are you working on a project to incorporate the patient-generated data?
Yes.
For example, yeah.
We